You know, CABG has been done for about 40 years now, but there's no real guidelines on the choice of conduits for CABG. Now, if you would please check the October 13th issue of JACC, because there is a review topic of the week on the choice of conduits in coronary artery bypass surgery. And I'm with one of the authors of that, Dr. Filippo Crea, who is an MD and professor of cardiology and the director of the Department of Cardiovascular Sciences at Catholic University in Rome. I enjoyed looking at your paper, and you note that there is this clear contradiction between the proven benefits of arterial grafting and the very limited use of arterial conduits in everyday clinical practice. How are you addressing this topic? What are you covering in this review paper?
Well, the idea stems from the observation that in the States, not more than 5% of patients receive a second arterial conduit. And in Europe, this percentage is slightly higher, the order of 10–15%, but still pretty low, despite overwhelming evidence that arterial conduits work better than vein grafts. I'm not a cardiac surgeon, I'm a cardiologist, but I stimulated my cardiac surgeons, Dr. Massetti and Gaudini in my institution, to consider a review article addressing this issue. And this has been very fruitful, because eventually it's not been our effort only, but this is a global review article with cardiac surgeons from Europe, including Dr. Taggart from UK, from Japan, Dr. Suma, and from the States, Dr. Puskas. So it's been really a global effort.
If there is a reason, when you ask surgeons, why aren't you using an arterial graft, what do they say?
Well, this is a very good question. They say we should use it more frequently. That's the answer.
Okay. They don't do it, but
no,
they
they don't do it. I think the main reason is that because there is a perceived observation that the complications with using more arterial conduits is more than using the left mammary.
Is it?
But it's not the case. I mean, it is a slightly higher incidence of wound complication and mediastinitis, in particular using the double internal mammary in diabetic patients and in patients with severe chronic pulmonary disease. But in a randomized trial, the ART trial carried out by David Taggart in the States, the risk of a perioperative complication was the same in patients with single mammary and patients with double mammary. So I think that is a misperception of what happens to our patients. This is why I thought it was appropriate really to focus on this issue. And this review article shows quite clearly that a second arterial conduit works better than a single internal mammary. For instance,
lasts longer?
Well, the patency rate is much higher with regard to the right internal mammary. The patency rate at 10 years is in the order of 90%. And unfortunately, we don't have a randomized study. The only randomized study is the ART trial, which started couple of years ago, but the primary endpoint is mortality at 10 years. So we have to wait a long time to have the results of this randomized trial. But there are brilliant meta-analyses involving 80,000 patients and showing that at 10 years, mortality rate is lower in patients treated with double mammary compared to single mammary. But the right internal mammary is not the only conduit surgeons can use. The radial artery works pretty well. For instance, in patients at risk of mediastinitis, it's perhaps better to use the radial artery rather than the second mammary. And also the gastroepiploic artery, as shown in his pioneering study by Dr. Suma many years ago, is a good alternative, a good option for the right coronary artery. The important caveat is that both the radial artery and the gastroepiploic artery can only be used when the native artery has got a severe stenosis, more than 90%, because if the stenosis is less than 90, if it is mild, then the risk of the arterial occlusion is not acceptable. But if the stenosis is severe, then they work pretty well. And with the radial artery in particular, there are 4 randomized trials showing that the patency rate after 1 year is by far higher with the radial artery than with the vein graft. And in meta-analysis, there's also disadvantage in terms of patency becomes an advantage also in terms of mortality. So the data there, it's time for action.
Is there any idea perhaps that they're holding the arterial grafts for later in case the patient needs a second or third revascularization? They don't want to use it right now?
Well, I think that because of their long patency rate, it's better to use them in young people more than in the elderly. No, I tell you, I think that this is a misperception of what's happening in daily life. It is also to consider, we have also to consider that technically it's a bit more demanding, but not so much. On average, it takes about 25 minutes more to have an arterial conduit more than a vein graft. What I do in my daily practice, and I think this is really the way to go, is to start with a nice heart team. The heart team is very, very important. In my institution, every morning we start with the heart team because it's the ideal place to perhaps create some competition between interventional cardiologists and cardiac surgeons.
True.
In our institution, the atmosphere is very friendly. We love to work together. But a bit of competition can help. Then when we have the difficult case, I ask my interventional cardiologist, okay, you put a stent there, but this is a diabetic patient, 3 vessel is definitely better for surgery. And then I ask the surgeon, okay, but what do you do? Vein or an artery? And if he says vein, I ask, but why? Because it's engaging, but I think this is the way to go. Data there have to go from publications to reality.
Well, it's a fine paper, and please take a look at it. It's in the October 13th issue of JACC. Dr. Crea and colleagues discuss current evidence for the use of different conduits in coronary artery bypass surgery, and they propose an evidence-based algorithm for the choice of the second conduit during CABG. For Cardio Source World News, I'm Executive Editor Rick McGuire.